Yeah, while Teresa is loading the next slides, I'm going to introduce our next speaker. This is Dr. George Mazariegos. He is the Chief of Pediatric Transplantation at Children's Hospital of Pittsburgh. He and his team have performed numerous liver transplants in patients with UCDs. He and his colleagues also recently founded the Starzl Network as a learning health network to spread best practices for children receiving transplantation. So on a personal note, I mentioned that my nephew has citrullinemia. He was actually transplanted at Dr. Mazariegos' hospital in 2015, and it was transformative for him. He had a rough go with medical management, and his life has significantly improved since the transplant. So I want to thank you, Dr. Mazariegos.
Thank you so much for that kind introduction and for the opportunity to present about a long-term perspective on liver transplant. I don't have any disclosures. I am thrilled to be on the medical advisory board of the NUCDF and to be able to collaborate with all of you in the room. I hope that the goal of my time with you this morning will really just be to give you a long-term overview of transplant and give you a little bit of the context of where we are right now. And also just to, perhaps for the families who are considering transplant, to learn from those that have gone through transplant, and for those that are considering to be able to know what questions to ask for your physicians and your surgical teams, and to connect with others who have been on that journey with you. What I really love about this room and this context is that really we are all here together to identify what the best solution is for our children. You know, whether that is medical therapy, gene therapy, or transplant therapy. I love how this slide from Dr. Vockley, my colleague, demonstrates that there are multiple options, and these are evolving and changing. So our mandate as physicians and surgeons is to provide the very best option, not to give you only our option, but to really work together to determine at this point in time what is the best therapy for your child. And I'll focus on transplant, but I'm excited to be in the room with all of you who are determining all of these multiple avenues of growth and of progress in this field. I am privileged to have trained under Dr. Thomas Starzl, really the founder. We call him the father of liver transplantation. And one of the lessons among the many that he taught me was to work closely and to develop this intersection of surgery, physician expertise, and patients to address the needs of the time. And I think this intersection particularly was relevant for metabolic disease because it exemplified the ability for these type of collaborations to lead to innovations and therapies starting many years ago. One of the most famous ones, of course, was Stormy Jones. This is the story of Stormy, who had a combined heart-liver transplant for hypercholesterolemia on Valentine's Day in 1984. And in his memoirs, The Puzzle People, Dr. Starzl wrote, if the fundamental defect was exclusively or primarily in the liver, it was conceptually possible then to correct the problem by replacing the liver. And this concept 40 years ago was transformative in the field of transplantation, but also transformative in the field of metabolic disease. And he writes in The Puzzle People, which I recommend to any of you who are interested in the story of transplantation. I just reread it to glean even more kernels of truth and of insight that really continue to inspire us in the field today. He wrote that armed with information from all of the lines of inquiry that were available to him at that time, which were primarily pathology studies of the explanted tissue and biochemical genetics, which was developing, and we've heard some of that pathway that we heard about this morning. More than a half dozen such inborn errors were cured metabolically between 1969 and 1983 by liver transplantation, first in Denver and then in Pittsburgh when Dr. Starzl moved there in 1981. So what I want to show you today is a little bit of the arc of transplantation and how it affects metabolic disease. I chose to separate it into 4 areas, which I've put here as the early 69 to 81 area. This was the era, and I'm combining them with the main immunosuppressant therapies at that time. There's other factors that are relevant, but for the purpose of this discussion, I separated into immunosuppression. In 1969 to 1981, the community, the transplant community that was innovating in transplant really just had 2 drugs, steroids and azathioprine, or what's commonly known as Imuran, and it's sometimes still used today. There were no further advanced agents. It wasn't until the 1980s that cyclosporin came onto the fold, being developed in the UK and with Roy Kahn, that first allowed there to be progress that was meaningful in survival of kidney and liver transplant grafts. And this corresponded with those early cures that I spoke to you about that for the first time had sustained survival. In 1991, when I first arrived in Pittsburgh to begin my fellowship, the early application of FK506, which then became known as tacrolimus, was being trialed there. And within about 10 years, additional centers, most centers in the United States and then in Europe, had adopted this version of a calcineurin inhibitor called tacrolimus. In the final era, which I have included as the current era, 2001 to 2024, continues to be based primarily on tacrolimus. There hasn't been another transformative development in immunosuppression. It has included the augmentation of different toolkits, including antibody therapy, which we call induction antibody, sometimes is used in some of our patients now with thymoglobulin or basiliximab, other induction agents that may allow less strong use of calcineurin inhibition. And there's been improvements in monitoring for infectious disease complications, and these have gone side by side with the development of surgical technique and expertise in what we refer to as technical variant grafts, which are non-whole grafts. They can be living donor grafts, they can be split grafts, and these are particularly relevant for the urea cycle population because the optimal graft for a small baby is not a whole liver, or may not be the whole liver that we typically used in the early eras. And so we'll talk about the combination of immunosuppression and these surgical techniques that may be most applicable. And then we'll conclude with talking about what's next in the next era of developments that will make these therapies even more broadly available for your children. What is important to note is that we have known from the beginning, from those early studies of Dr. Starzl, that of the many metabolic conditions, what is most exciting about this bucket in the lower left-hand corner, which includes the urea cycle disorders, is that there is no disease recurrence after the liver is replaced because the defect is limited to the liver. And so in this bucket of metabolic conditions, including the urea cycle disorders, that disorder is cured with a liver transplant, and we can focus on minimizing the other complications related to the transplant procedure itself. So in the next 25 minutes or so, I'm going to talk really about 3 things after this introduction. One is, what are some of the key decision points and long-term outcomes of liver transplant that you can expect today? I want to give you some perspectives on things to ask for your practitioners that would help inform you. I want to talk about some of the challenges of variation in care across the United States that does impact decision-making for patients and their families, and that is not always reflected well in the studies or the data that is publicly available. I'll touch briefly on learning networks and what we are focusing on in our learning network system on challenges for the future, including transition of care and immunosuppression, and briefly talk about supplementation in your patient populations after a successful transplant. So let's talk about 3 of the 3 key topics about long-term outcomes after liver transplant today. The first one, and we saw last night those who raised their hands who've had a transplant in the room, you are part of a growing and wonderful community. This is data just analyzed through the end of last month. where we have now over 35,000 children transplanted under the age of 18 who are living in the United States with healthy kidney, liver, heart, and intestine allografts. So these are representing each of the different organ types. The liver is here in the orange, and over 12,000 recipients of liver grafts in the United States have those grafts and are living successfully in their communities currently today. The second important point is that this community not only drives the questions and the work that we're doing, but it's also an important testimony to the success of transplant, and that you are not alone. You are part of a community that can learn together and can learn together in many cases, not focusing on their primary disease, but now focusing on the opportunities of learning how to live successfully with a liver transplant graft when their disease has been cured. So you can join a much larger community of patients and individuals and learn and walk together in this. Most families appropriately want to know, what is the expected outcome from transplant, and will I need another liver transplant in my lifetime? And this data, which is statistically projected data based on United States actual data, shows that we have an excellent expectation of a long-term outcome for those patients who've been transplanted in the most recent era from 2007 and beyond. So you can see that those upper curve here, this is for patient, and the bottom is for graft, meaning does the patient need a retransplant? The projected outcomes for 30 years are now 80% patient survival and 70% graft survival, meaning that there's about a 10% chance of a retransplant of the liver over 30 years for children transplanted in the United States in the most recent era. And this is important information to arm yourself with. This data is cumulative. It includes all centers. It includes all diseases. And as we'll talk about in a few minutes, we can expect that the outcomes for metabolic conditions actually may present an even greater chance of success, because typically chronic liver disease such as biliary atresia or liver disease for acute liver failure or cancer have a lower long-term prognosis outcome. And so therefore the metabolic conditions really can be expected to have a higher long-term outcome. So good news again. And then finally, this is data from Dr. McKiernan, and who was working with us at the time, who analyzed United States data, is, as we've shared before, the proportion of children being transplanted for urea cycle disorders continues to increase. This is due based not only on the improved techniques and outcomes that I've just shared, but also an increased awareness and awareness of the success with liver transplant in the United States over the past 30 years. As we talk about in this morning session, the benefits and risks and decision making, there are many aspects which are critical to understand both on the medical and surgical side. And I hope to be able to give you an adequate and accurate overview, or at least arm you with some important questions to ask. Of course, it varies on the phenotype, the frequency of decompensations, whether there is end organ damage, like Lindsay talked about in the liver already. We talk, and I'm going to talk extensively about some of the important questions on the liver transplant side, but with an emphasis on really understanding the available expertise at your site and at sites nationally to obtain the best outcome possible. The initial data when we analyzed outcomes after metabolic disease are summarized in these two important studies, which are now 20 and about 15 years old. The first one on the left side looked at OPTN data, which is the mandated United States reporting data, the Organ Procurement and Transplant Network data. This bar demonstrates non-cirrhotic metabolic conditions, and you can see the 10% survival advantage over the typical indication for liver transplant, which is usually biliary atresia. In a later analysis looking at the studies of pediatric liver transplant population, which I had the privilege to work with, the similar results were demonstrated with the metabolic outcomes being superior to the non-metabolic transplant outcomes. And we'll show a little bit more of the detail on that. For this summary of this meeting, I had our team update our own personal series in Pittsburgh, and also want to contrast that with the Japanese registry, which is a large international Japanese registry, mostly focusing on living donor liver transplant. In our series currently through December of last year, we've transplanted 404 children with metabolic conditions. 45 of those include urea cycle disorders. And you can see the important trend and improvement in evolution of outcomes with a patient survival of 90% at 25 years for our study for patients transplanted since 2000. And this compares favorably with the Japanese group, again showing a similar 90% survival for a slightly smaller cohort of children transplanted from 2006 and beyond. The selected results in the published literature continue to evolve, but these are the representative samples that you can find and are available to you for further study. I won't go into all of them. I've referenced two of them already. There's two single-site reports that are important to review. One is the Stanford data that was published about 10 years ago, and our own data that I'm presenting now, as well as a published report from Pittsburgh about 10 years ago. And the Japanese study that I have referenced. In general, I just want to point out two caveats. When you look at data that reports on the OPTN or Society of Pediatric Liver Transplant, typically those outcome data are going to show very limited survival outcomes. They're going to show only 1 or 5 year survival outcomes. So you can see you'll have to be take care when you read those data to understand that those are data projected based on what they know in their registry to be 1 and 5 year data. The benefit of some of the single center like our Stanford or Pittsburgh data is that we're able to provide 20 or 25 or 30 year outcomes because of the available data within that center that can present that information to you. So you want to obviously ask your center, what is your overall experience and what are your long-term outcomes? And by long-term, we emphasize 20 years or greater. The study from Split also characterized the differences of the different metabolic conditions. So, for example, they included urea cycle, but also alpha-1, Wilson's disease, maple syrup disease, and other neonatal conditions. And so you want to be able to understand that the data is focusing on a variety of metabolic conditions, not just urea cycle disorders. The living donor experience is an important one. This is the focus of the Japanese study, which only typically uses living donation because of the cultural emphasis on living donation and the focus of that therapy. So you can see exceptional outcomes have been obtained with living donation and has become a focus of ours in Pittsburgh as well, primarily because these may be the optimal way to transplant young children in a period of time before further neurocognitive impact is inflicted upon them through the course of their natural history, as well as split liver transplantation. So this data from the Japanese group details some of their experience with the living donation in a group of about 50 children with urea cycle conditions, low technical complications, and good outcomes with living donation. And similarly to the data that Dr. McKiernan wrote, the increase in transplantation for urea cycle in Japan and in other living donor-focused communities continues to grow as it is doing in the United States. I was excited to see that one of my transplant kiddos is not only better looking than me, but she's also taller than me. That's Sophia, who's going to be, I think, up on the stage in a little bit. And so that certainly corresponds with some of the data that recently has been published on growth and on neuro events and control of ammonia after transplant. This data has been known, but the benefits of this study include a more severity-adjusted scoring system with the study group. You can see that in severe phenotype, both the hyperammonemic events have gone to 0 after liver transplant, and there's been a favorable growth after transplant compared to prior to transplant at the first observation. So growth and hyperammonemic events in this controlled study have been improved. Motor outcomes and cognitive outcomes haven't yet been shown in this cohort to yet be improved after liver transplant, and it still gives us an opportunity for further focus and further research and collaboration on optimal timing for transplant and how we can get the cognitive and motor outcomes to the very, very best possible state. I do believe that it's better to transplant early, although there are multiple factors, and I think Dr. Nicholas Amu is going to talk about some of the factors that go into decision-making. This is one study looking at OPTN data, again, United States organ procurement transplant data, 233 children over a lengthy period of time, that did demonstrate that further waiting time in this analysis did increase the odds of cognitive delay in this study cohort. The study measures, though, that are captured by the OPTN analysis are rather limited and are subjective, and so we need to improve further on the granularity of the data that is captured by the OPTN analysis. Right now, these are just, there's 2 functional scales that are used based on age that are recorded at the time of listing and after transplant, and this is what this data reflects. But the initial message is that earlier transplantation makes sense based on the data that they analyzed. I'm going to shift now into just giving you some further perspectives. One of them I won't focus on because I know Nick is going to talk about this, and this is the life cycle catalyst. I'm going to talk briefly about outcome measures and ideal outcomes. Again, more with a view to help you be armed with questions to prepare you and to give you confidence that you're making a good decision and that you have the right information to make the best decision for your child. I do love, however, this process and framework that Dr. Amu and colleagues published a few years ago that I think he's going to speak about in the future. And what this gives insight to is the dynamic process and multiple factors that go into decision making. We are not all the same. No child is the same. And there are multiple factors like the clinical factors, the disease severity, the social factors, your own experience and your own surrounding community and support group, the system factors, the availability of medical care may be vastly different in Chicago than it is in Brazil. And the personal experiences and factors that all work together to give a tipping point to when to consider liver transplant over medical therapy. And importantly, these factors do change over time, and so the factors that exist when the child is a newborn may be vastly different from when that patient is now a young lady considering college and still facing the challenges of medical care, and where transplant may then loom as a better alternative for that patient. The second one that I think is very, very important for us to consider is the Porter's system of outcome measures. Typically in transplantation and in any typical chronic disease or care point of view, we have always presented data on survival related to how well that intervention is likely to lead to survival. But we haven't done well at looking at the second tiers of outcome, which include the complications that therapy may involve, which includes how rapid a patient may get back to a normal life and the level of that normal life. And then thirdly, how, if any, what are the recurrences of the condition? So will that intervention be needed? In the case of transplant, will a retransplant be needed? What does life look like in terms of long-term outcomes related to retransplant? And then finally, the ideal outcome metric is something that was developed by the Society of Pediatric Liver Transplant to try to characterize additional factors besides just survival that would be important to inform and to be a benchmark against which we could measure progress. So this idea reflects to the concept of not only surviving after a therapy like transplant, but also having an optimal function of the graft. So is the biochemical parameters of the graft satisfactory? Is their biochemistry suggest that the liver is healthy? Is there absence of comorbidities such as lymphoproliferative disease, hypertension, or diabetes? And is the medication regimen satisfactory? Are they taking one drug versus more than one drug? Is there normal growth and other factors? These 13 outcome measures served as the initial benchmark for an ideal outcome after 10 years. In the first study that we did, about 33% of all the 10-year survivors had reached every single one of these benchmarks. It's a relatively high standard. Most had reached each individual benchmark, but when you ask the study cohort which had all of them, 30% of them had obtained them. And so we're working to continue to improve that at a center level to get to 75, 80% ideal outcome for our patients. And then in the last couple of minutes, I want to just focus on some improvement areas and on some of the variations in care across the United States to, in a constructive way, give you insight and talk about learning networks. Last December, I published this data with collaborators from our learning network, the Starzl network, which looked at the center use of technical variant grafts, which, as I mentioned, I believe are really the key to successful outcomes in the United States for urea cycle conditions currently for most infants. Our question was, how did the center use of technical variant grafts vary across the country, and did that matter? Did that impact on outcome? So this scatter plot, which was published in Liver Transplantation, demonstrates a few things. So each of these dots here is an individual transplant center. The larger ones have a larger volume over the 10, 15-year study period. Each dot is an individual transplant center in the United States that had done at least 10 transplants over the study period. And on the x-axis is the proportion of the use of either a living donor or a split liver graft, and on the y-axis is the waitlist mortality. So the take-home message was that there was a wide variation in practice. So centers across the United States, independent of geography or where they were, had varying practices. It wasn't dependent on whether the center was large or small, and it didn't significantly change over time. But what you did see was that the use of technical variants, either split grafts or living donor grafts, was independently and in combination associated with better outcomes and lower waitlist mortality. We believe that in pediatric liver transplant, we can achieve a zero waitlist mortality using the techniques that are available today. Every child should get a transplant in time, but yet we currently still have about a 5% waitlist mortality rate in the United States overall. So we're working diligently at the center level to not have that happen ever. But it is through the use of these technical variant grafts that I think we can achieve that. The second message that we also saw from this analysis was that living donor liver transplant had significantly improved survival from transplant compared to the other graft types, but that the split graft type in the lower green was statistically equivalent to the whole liver grafts. So those should not be considered to be an inferior graft at all. And so whole liver grafts may not be available for small children depending on the center that is using them, and other techniques do need to be utilized. Finally, I want to close by talking a little bit about learning networks. I think your consortium and this foundation is a wonderful example of an early to the playing field of learning networks, because you have been focusing on accelerating care, and learning systems are being utilized increasingly to try to learn faster. And I have learned a lot from your history in doing the same thing with liver transplantation with our Starzl network learning system. But what you are undoubtedly frustrated with, as I was that we don't have time to wait the typical 15 or 20 years of a randomized control study to reach the bedside. Children can't wait is our mantra. And so the learning system process is to try to move iteratively faster, including patient voice and centers to drive knowledge of the bedside faster. And our learning system, the Starzl network, now is a 16-center North American learning health system focusing on 4 areas. We picked these 4 areas because they do represent some of the challenges of liver transplant over the long term, and they are technical issues, surgical complications, immunosuppression, and how do we advance collaboratively together, quality of life assessment, and then planning for transition into adult care. These are 4 of the burning platforms, if you will, that the network chose. I'll focus just very briefly about what we're doing on immunosuppression, just to give you an idea for those of you who have been transplanted. We need to optimize immunosuppression outcomes, and right now the variation in practice is quite stark. We did an analysis that analyzed how centers were practicing immunosuppression, and we found this data that we just published looking at the steroids or induction antibody and another drug called MMF or CellCept, and each of the bars here represents a different center and their use or non-use of those drugs. So what we hope to do in the Starzl network is to develop consensus protocol development, protocols where we simplify the multiple menu items into a more focused and trimmed menu, so to speak, so that we're all ordering off the same menu, and that from there we can lead to comparative effectiveness trials. I think I'll close there. I had a little slide on supplementation, but I don't want to take up too much time, and we'll talk a little bit more about that in the conclusion and then discussion times. But I hope that this brief overview has shown that the outcomes that you can expect after liver transplant can be exceptional, but do vary by center. We do need to develop optimal timing for transplantation and to study that. And we need to be frank and present data on long-term morbidities with a view on ideal outcomes for both medical and transplant options. And this is our mandate based on the community of 30,000 children that are now living with healthy grafts after liver transplantation. Thank you very much.